All right, I'm very pleased to announce our next set of guests. This is a formidable partnership and collaboration. With over 25 years of experience in digital strategy, product innovation, and engineering, leadership, and enterprise transformation, Dr. Adrian Moise is the founder and CEO of Aequilibrium. He holds a PhD and postdoctoral fellowship in computer science and background in healthcare with experience as a technical architect in medical imaging and e-health. He has held leadership roles at Microsoft, Electronic Arts, IQ Metrics, and Blast Radius. He built Aequilibrium from a startup into one of British Columbia's top 5 digital agencies and top 100 fastest growing companies, recognized for its award-winning work in digital product design and immersive personalized learning using XR and AI. Isabela Moise is the product owner at Aequilibrium, specializing in immersive learning, AI-driven experiences, and digital transformation. She leads project strategy and execution for Aequilibrium's VR Training Academy, designing and delivering VR and AI-powered training solutions across industries, including healthcare, academia, and financial institutions. She also co-leads VR4Health, an ITEA global consortium project focused on enhancing healthcare training using immersive AI-powered learning, with a background in computer science and business from Berkeley, and experience on AI teams within global technology organizations like Microsoft, PricewaterhouseCoopers, and Slack-affiliated consulting teams. She brings a unique blend of technical fluency, research depth, and user-centric product thinking. Please welcome Adrian and Isabela Moise.
Hello. Hi, everyone. Good morning. Thank you for joining us for this exciting session. We will be talking about an exciting shift that's happening today in how we do education for the next generation of healthcare workers. We will show you how AI-driven virtual reality will be used to drive better emotional resilience and using instinctual action to improve patient outcomes. I've been doing work in this space for over 25 years, starting with healthcare, where I build medical imaging workstations for McKesson Medical Imaging, then went into gaming, and both in Europe for Ubisoft and at Electronic Arts helped build the mobile gaming division and created edutainment applications that have trained millions of users. And then lastly, my PhD and postdoc in computer science focused particularly on the e-health space, and we look into indicators such as cognitive workload and information coming from eye tracking and gaze to understand how it impacts accuracy, speed, and workload for clinicians. We know how to train high performance in industries such as aerospace and Formula One. Learning from this industry, we will look how to apply that into healthcare.
But before that, my name is Isabela. I'm the product owner at Aequilibrium, and my specialty is more in AI-driven immersive learning. I lead product strategy for our VR Training Academy and co-lead our VR4Health program, which Adrian will explain a little bit more in a moment. But essentially, the idea and goal is to truly revolutionize how we teach individuals healthcare competencies, from the psychomotor to the cognitive, even to the emotional. And all of that together in a completely lucrative and comprehensive education platform.
We're also leading this R&D initiative with ITEA. It's called VR4Health. After 18 months, this 3-year, $10 million funded project with 4 other countries is about to start. And the work that we're doing there also builds on our partnership with Keough Research Institute. The focus for us is to build this immersive and personalized experience for education and training that solve problems not only in Canada, but also internationally.
And as for today, what we'll be going through is first describing the crisis of readiness in healthcare that we are aiming to resolve before breaking down our model for rectifying this crisis by transforming the education layer and illustrating this by walking you through 2 use cases that use tangible VR and AI applications, and finally discuss how you can implement these types of innovations to augment your own education ecosystem. And so we begin. The idea here is that, oh dear, well, presumably there is normal text on the actual slides, but the idea here is that the gap between theory and application is increasingly widening, both for those newbies to the floor that have those simulations and learning that they have thus far from the textbooks in the classroom, really just lack the overall high pressure testing that actually being on the floor provides, giving way to reality shock. This is so much so that this loss of learning actually begins before they even set foot on the floor after their first year of education. And this type of loss of knowledge really manifests itself in those newly graduated students as being wholly underprepared. For example, in one study finding that only 23% of new grad nurses actually qualified and showcased the type of competency and judgment and diagnostics that was suitable for someone in their first year on the floor. And for veterans of this hospital space, the often typical, slightly dreaded quarterly training workshops that take you away from the floor can't keep pace with the dual force of 1, the speed of medical innovation, and 2, the decay of skills that they don't really have the proper educational resources to amp up and ensure is at top speed in order to apply it onto the floor. And so senior staff are, in fact, being left underprepared for the very protocols they are expected to eventually lead. And this all underpreparedness manifests itself both psychologically and the economics of operations and in the overall decline of the patient's experience. To begin with the mental element, this underpreparation has significant effect, especially on the psyche of the newcomers, because from the fact that their confidence to their sense of safety, all of which takes a massive hit once they get into the quote-unquote reality of healthcare. And this puts them through many intense emotions throughout the entirety of their day on a daily basis. And as a defense mechanism, this eventual intensity gives way to empathy erosion and a sense of detachment as a way of numbing this type of overwhelm. And eventually, they reach a degree of burnout and detachment that prompts the attrition into new roles or professions that obviously the healthcare system cannot afford at the moment. And this only exacerbates the pressure that the remaining staff have to experience, who also feel the type of burnout, overwhelm, and emotional erosion that perpetuates into further attrition. And when those floors in the staff is not only underprepared, but combating burnout for themselves and understaffed, obviously more mistakes get made. And what that means specifically is that, for example, elements of a patient experiencing an adverse effect and an adverse event increases their overall time on the bed or in the patient room from 6 days to 28. And that's 22 extra days that another patient couldn't be in that bed, and that's another 22 days that this patient has to be in the rotation for existing staff. And what's more, all these types of adverse events eventually leads to 50% of total hospital expenditures now being linked to that error management, which I'm sure we all agree could be better invested elsewhere. And as a result, that's basically can serve as the tax of healthcare institutions pay for that lack of readiness. But ultimately, the real payment is down to the patient, as they pay an even greater price, with 10% of patients experiencing harm during acute care, and up to half of those events actually being preventable in the first place. And overall, this has led to a drop of 31.4% trust in the public and US healthcare system since 2020. And a lot of it has been attributed to this perceived lack of emotional, well-intentioned, and empathetic care experienced by these patients.
So what you're seeing here is a traditional feedback loop. The lack of preparedness, leads to an empathy breakdown in the conversation with the patients. The care provider is feeling stressed and burnout, has to do work after, and feeling unprepared for the job, and the extra pressure on they feel under can lead to attrition, people looking for jobs that are better fit with their background. So it's actually the system that's putting people under these situations of where they cannot succeed. In cognitive science, we know that under stress, people behave differently. Their working memory is affecting, the decision making is affecting. So if you train people under non-realistic conditions, you do not build transferable skills that are applicable under real working conditions. So event-based training has several disadvantages. It's expensive, it's hard to sort of deliver, it's infrequent, there is a shortage of rooms, and it does not scale. In addition, it's often not personalized. Everybody's watching the same boring videos, they're going to grab a coffee and then come back at the end of the training scenarios. In contrast, the training that we're proposing are a better replica of the real world environment in which the clinicians have to perform. So as opposed to being into like, I'm at home, I'm relaxing, I'm having a coffee and watching these videos, we can put people under very realistic training environment. Plus, in virtual reality, there is a wealth of data that's present in no other environment, from eye tracking to pupil dilation to voice stress to sentiment. Combine these things, not only train clinicians in behavior, but we're also measuring their cognitive load in real time.
So let's get down to how do we solve the crisis that we've outlined thus far. And we want to begin essentially by reinvigorating the entire education system and focusing more on reinforcement care and that reinforcement loop. Essentially, we call it care inoculation. We move from that event-based quarterly 3-hour workshop that everyone's super glad to be a part of, or in the med school circumstance, those long-lasting lectures, into what we call a loop. That means we provide immersive, just-in-time, low-stakes doses of high-pressure scenarios to allow for like a continuous and gradual introduction of those applications, those skills, that eventually you'll be able to much better recall live on the floor. This overall flattens that forgetting curve and builds the instinctual active recall that's needed to withstand the hospital pressures. In other words, we like to be cute on the marketing side and say that it's essentially a booster shot for clinical readiness. Using VR and driven by artificial intelligence, these booster shots for clinical readiness allows quick, targeted exposure where we help learners build the cognitive, quote unquote, antibodies they need to effectively apply their learning in reality. And so now I want to illustrate this type of solution with 2 use cases that we find the most promise and the most compelling answers to. So the first of which is AI-driven virtual patients, for learners to really focus on their bedside manner and for educators to basically scale the development of emotional intelligence. And so it highlights that the power of this platform and our VR4Health solution actually begins before a learner even steps into the VR environment. It actually starts with the authoring capabilities that empowers these educators, these subject matter experts, to remain the architects of these experiences, largely autonomously, to create the training for themselves. So you can give these virtual patients specific motivations, symptoms, medical histories, but also, more importantly, personalities as well as motivations. And because of that, you can even do things like draw from anonymized patient profiles and data to ensure that the individuals you are interacting with virtually actually reflect the communities you are there to serve. And on top of that, you can, for example, if you have a scenario where you're dealing with a difficult conversation around vaccine hesitancy, you can actually give them these types of patients, or you author them in a way that they're maybe skeptical, maybe they use specific community jargon, maybe they have more of a misunderstanding that is common to a certain group of people, all of which is more of an archetype of what you would actually visualize in the real world. And that means you can also apply and practice these conversations as many times as necessary in a way that is personalized and gives you that coaching that is just as gentle unto yourself that you need to be with your patients. On top of that, whether it's an accessible practice so that you can prep for the med student's next OSCE exam or some type of complex anti-bias training, this AI dynamically applies all these traits that the educator authored into this training scenario. And because it's available on a portable headset, this means learners can practice these interactions whenever and wherever it suits them. So that 15-minute gap potentially between your rounds or between classes all of a sudden becomes a high-intensity, just-in-time learning experience. The second case study I want to talk about is the high acuity scenarios, in which we solve the dangerous gap in healthcare where these low frequency but very important events think of code whites or code blues, are too expensive to really simulate on a frequent level, but are way too important to just teach on a PowerPoint slide. And you can't really read your way into a proper critical response. And so what we've built is that holistic training loop that hits the 3 pillars simultaneously that I spoke about before: psychomotor, cognitive, and emotional. Cognitively, you're following the complex hospital protocols, right? Psychomotorly, you're doing anything from interacting with the equipment to engaging with individuals to shutting down elements if you so need. And emotionally, we're training your nervous system. You have to make those split-second decisions while AI avatars are shouting at you, while there's ambient noise and things are a little bit chaotic, to say the least. And you're not able, and so because you're able to develop that like in VR, then once you actually hit the floor, you're able to do what your instincts tell you to, which you've developed through VR. And to make this immediately applicable, we also are able to 3D map the exact space of, let's say, your hospital or your department in these so-called digital twins. So your real workspace is what you're working with in VR. And so this means that an individual doesn't have to have their brain translate these hypothetical generic situations they deal with in VR, and rather, it's immediately recognizable.
So Isabela provided several examples of how we do both soft and hard skills training, but this is not the regular training. It is this high performance training in which these highly immersive, personalized scenarios enable to augment education while providing compliance, adaptation, and confidence. And then all the stakeholders from the healthcare system see benefit from that. From administrator with reduced errors, with department heads, they see gaps, they are able to fix it, and the learners, they get to get this training available anytime, anywhere, personalized, able to scale. So similar to how high-performance training is delivered in gaming, aviation, and Formula One, now it's time to apply this type of practices into healthcare. So we have a booth right here, just outside, and we're showing some of the work that we're doing. We work internationally, both with clients in the United States. We're visiting one of our clients in a couple of weeks. We'll also be present at the AWE conference in next month. Please come at our booth. We'll give you some examples of how to apply this in practice. And you can also learn more about the VR4Health international program that we're leading and about our platform. Thank you very much for your attention.
Thank you.